Welcome to the image analysis of the foot. We will review common projections of the AP axial, the medial oblique, and the lateral foot projection. We will review the image analysis guidelines for each of those, common positioning errors, and how to take corrective action. Image analysis guidelines for the AP axial foot projection state that equal spacing between the second through fifth metatarsals should be evident. 1/3 of the talus is superimposing the calcaneus. In a non-weight-bearing projection, the joint space between the medial first and intermediate second cuneiform is demonstrated as open. The tarsometatarsal and navicular cuneiform joint spaces are open. The third metatarsal base is at the center of the exposure field. The proximal calcaneus, talar neck, tarsals, metatarsals, phalanges, and foot soft tissue are all to be included within the exposure field. Here are those image analysis guidelines for your review. In an AP foot projection, proper alignment is crucial to achieving an accurate image. The medial side of the foot generally arches up between the heel and the medial 3 metatarsophalangeal joints, forming a visible longitudinal arch. This arch causes the medial plantar surface to not always make full contact with the IR. In order to avoid uneven plantar surface pressure and rotation, it is important to position the foot so that uneven pressure is placed on the plantar surface. However, if the foot is improperly aligned, rotation can occur. In lateral rotation of the foot, there will be a increased superimposition of the metatarsal bases, closure of the medial and intermediate cuneiform joints, and the talus moves over the calcaneus, causing more than 1/3 of the talus to be superimposed by the calcaneus. When there's medial rotation, there'll be decreased superimposition of the metatarsal bases. Closure of the medial and intermediate cuneiform joints is demonstrated, and the talus moves away from the calcaneus. This results in less than 1/3 of the talus superimposing the calcaneus. To avoid these errors, you want to ensure that the foot is properly aligned for the AP axial projection, whether it's weight-bearing or non-weight-bearing. You want to take care to prevent that there's any medial or lateral foot rotation. This alignment allows for clear and accurate imaging when properly aligned. Employing proper central ray angulation is very important for the AP axial foot projection. When you're not utilizing the appropriate central ray, the results can be indicative of an obstructive tarsometatarsal joint spaces being closed and the navicular cuneiform joint spaces being closed. We want to ensure that we have that 15-degree axial angle on for that for this projection. Go ahead and review this first practice analysis and answer the following question. In this AP axial foot projection, the following misalignment can be observed. if you look closely, we have some joint spaces closed. The tarsal metatarsal joint spaces are not demonstrated as open. Neither is the navicular cuneiform joint space. This should indicate to you that the central ray was not aligned parallel with these joint spaces. So in order to correct this, we need to direct that central ray 10 to 15 degrees proximally, or angle the central ray until it is perpendicular with the dorsal surface of the foot in order to ensure that joint spaces are properly demonstrated as open. Go ahead and review this next practice analysis and answer the following question. So let's review this next practice analysis together. In this AP axial foot projection, there are a few positioning errors. If you look closely at the medial and intermediate cuneiform, the joint spaces are closed. There's no talar superimposition of the calcaneus, which should indicate to you some rotation error. And there's decreased superimposition of the metatarsal bases. This indicates that there's excessive pressure on that medial plantar surface, which has caused some medial rotation. In order to correct this imaging error, we need to rotate that foot laterally until pressure is evenly distributed across the plantar surface. For non-weight bearing projections, you want to ensure that the lower leg and ankle and foot are aligned. But for weight bearing projections, you want to position the hips, position the knees and feet and hip width apart in order to ensure proper positioning. Let's move on to the medial oblique foot projection. Image analysis guidelines for the AP oblique foot projection state that the cuboid cuneiform and 3rd through 5th intermetatarsal joint spaces should be demonstrated as open. The tarsus sinus and 5th metatarsal tuberosity are visualized. The 3rd metatarsal base is demonstrated at the center of the exposure field. The phalanges, metatarsals, tarsals, calcaneus, and foot soft tissue should all be included within the exposure field. Here are those guidelines for your review. In an AP oblique foot projection, the degree of foot obliquity required to open the cuboid cuneiform and the 2nd through 5th intermetatarsal joint spaces depends on the height of the medial longitudinal arch. Higher arches will require more obliquity, while lower arches require less obliquity. With that being said, how do we determine the appropriate obliquity? Well, let's refer back to our AP foot projection. When you conducted the AP foot projection, which usually is done first in the series, was the central ray less than 10 degrees to open that those joint spaces? Because sometimes those joint spaces at a 10 degree central ray are still closed and it's too much angle, so you may have to decrease. So if it was less than that 10 degrees, that should indicate to you that you had a low arch. Therefore, the foot should only be positioned for the medial projection at 30 degrees of obliquity for the AP oblique foot projection. However, generally speaking, if the central ray angulation for your AP projection was around 10 degrees and your joint spaces were open on the AP foot projection, then that's indicating that that was an average arch, and therefore the foot should be positioned at 45 degrees of obliquity. If your central ray angulation for the AP projection was still insufficient and you had to increase that central ray angulation to 15 degrees, that should indicate to you that you are dealing with a patient that has a high medial arch. They have a high medial arch. You want to increase that foot obliquity to maybe even 60 degrees of foot obliquity. Typically, you're dealing with average medial arch patients, and 45-degree foot obliquity should be sufficient. However, these are just a little bit of tips and tricks for you to identify when to increase or decrease rotation of the foot in order to get that cuboid cuneiform joint space open and that 2nd through 5th intermetatarsal joint spaces open. So now let's look at what happens or how to identify insufficient foot obliquity. When the foot is insufficiently obliqued, the longitudinal joints such as those cuneiform, cuboid, navicular cuboid, and the 3rd through 5th intermetatarsal phalangeal joint spaces will remain closed. The projection will still look like it is a AP projection almost. To determine if the foot was rotated too little, you really want to check that 4th and 5th metatarsal joint space. If the 4th metatarsal base is superimposed over the 5th, the foot was under-rotated. Now, on the other hand, in excessive foot obliquity, this results in a closed 4th through 5th intermetatarsal joint space, and the 5th proximal metatarsal is demonstrated in profile, superimposing the 4th metatarsal tubercle. In addition, the sinus tarsi will not be visualized as well. Go ahead and complete this first practice analysis and answer the following question. Let's review this practice analysis together. In this AP oblique foot projection, you'll notice the following positioning errors. The lateral cuneiform, cuboid, navicular, and 3rd through 5th intermetatarsal joint spaces are demonstrated as closed. The 4th metatarsal tubercle is shown in profile and superimposing the 5th metatarsal. This all indicates that we are insufficiently medially rotated. In order to correct this imaging error or positioning error, you want to increase the degree of medial foot rotation until the required joint spaces are demonstrated as open. Go ahead and review this next practice analysis and answer the following question. In this practice analysis, again, the lateral cuneiform, cuboid, navicular, and intermetatarsal joint spaces are demonstrated as closed again. So we have a rotation issue. The 5th proximal metatarsal is superimposing over the 4th metatarsal tubercle. This indicates that there is some excessive medial rotation. In order to correct this imaging, we need to decrease that foot rotation until the joint spaces are demonstrated as open. Let's move on to the lateral foot projection. Image analysis guidelines for the lateral foot projection state that the metatarsal heads are demonstrated as superimposed. In a non-weight-bearing foot, the lower leg and foot are at a 90-degree angle with a neutral ankle joint. The proximal talar domes are aligned. The tibio-talar joint space is demonstrated as open. The distal fibula is demonstrated about a 1/4 inch distal to the distal aspect of the medial tibia. The average medial arch, or in the average medial arch, 1/2 of the cuboid is visualized posteriorly to the navicular bone. The talar domes are aligned anteriorly and posteriorly. The anterior aspect of the distal fibula is aligned with the mid-tibia. Posterior half of the distal tibia superimposes the fibula. The distal tarsals are at the center of the exposure field. The phalanges, metatarsals, tarsals, talus, calcaneus, 1 inch of the distal lower leg, and foot soft tissue are all to be included within the exposure field. Here is some additional pictures of accurately positioned patient in a lateral foot projection. Here are those image analysis guidelines for your review. I have provided for you a couple images of patients with different arches. The medial arch can vary in different patients, as we discussed earlier with the oblique projection. In this case, each one of these lateral projections represent a true lateral projection for the average medial arch, low medial arch, and the high medial arch. Notice the degree of superimposition of the tarsals and metatarsals may vary dependent upon the arch. But image analysis or evaluation criteria requires that the metatarsal heads be superimposed, which we have checked that in all 3 projections, and the talar dome should be superimposed. And again, we have checked that in all 3 projections. When evaluating the foot projection, you want to look at a couple different things. One is evaluating if the tib-fib relationship is accurately positioned. In a lateral foot projection, the domes of the talus align with the tibia when the lower leg is positioned parallel to the IR. If one talar dome appears more proximal than the other, assess the medial arch height, fibula tibia superimposition, and talocalcaneal joint to determine how to readjust the leg for proper alignment. When the lower leg is aligned parallel with the IR, the fibula will be slightly more distal than the tibia by about a 1/4 inch. If the leg tilts, this relationship shifts the fibula and becomes more proximal or distal depending on the tilt. For patients who have like thick thighs or difficulty extending their knees, you may need to use a sponge to elevate the foot in IR to ensure that that lower leg is parallel to the IR for accurate positioning. This is just an image indicative of an accurate tib-fib relationship. So let's talk about rotation and how to determine it next. In a lateral foot projection, the anterior and posterior talar domes are properly align when the foot is positioned parallel to the IR and even pressure is applied across the entire lateral foot surface. If one talar dome appears anterior to the other, you want to evaluate that fibula in relationship to the tibia to determine how to adjust the patient's position. With internal leg rotation, if the leg is the internal leg rotation, the lateral talar dome will move anterior to the medial talar dome, and the anterior fibula shifts anteriorly to the mid tibia. This results from the heel being placed down on the IR and the forefoot being rotated away from the IR. Here are those characteristics. Now when there's external rotation, the lateral talar domes shift posterior to the medial talar dome, and the anterior fibula moves posterior to the mid-tibia. This occurs when the forefoot is more in contact with the IR and the calcaneus is shifted away from the IR. Here are those characteristics for your review. So now let's talk about what is happening when you have an obscured tibio-talar joint space and one talar dome is superior and the other is inferior to one another. In a lateral foot projection, if the proximal talar or proximal lower leg is elevated farther from the IR than the distal leg, there can be a couple issues that can arise. The lateral talar dome will appear proximal to the medial talar dome. Less than a half an inch of the cuboid will be visible beyond the navicular if the patient has an average medial arch. The distal fibula may be positioned less than a quarter-inch distal to, or may even be proximal to the distal tibia. The talocalcaneal and tibio-talar joint spaces will also be closed. In order to correct this, we got to ensure that the proximal lower leg is depressed and the distal leg should be elevated a little to ensure that the foot is parallel with the IR. Now when the distal lower leg is elevated above the proximal, the lateral talar dome will appear distal to the medial talar dome. More than half of the cuboid will be visible beyond the navicular if the patient has an average medial arch. The distal fibula will be more than a quarter-inch distal to the distal medial tibia. The talocalcaneal joint will appear open, while the tibio-talar joint space will remain closed. In order to correct that imaging or positioning error, we need to lower that distal leg so that the lateral surface of the foot is parallel with the IR. Go ahead and review this first practice analysis and answer the following question. So let's review this practice analysis together. In this practice analysis of the lateral foot projection, you can see that the medial talar dome is positioned anterior to the lateral talar dome, which is indicated by the fibula's posterior position on the tibia. The tibio-talar joint space is closed, so that should indicate to you we've got some type of either elevation or rotation issue. In this case, the leg appears to be externally rotated and the foot is also in plantar flexion. We are not dorsiflexing this foot. In order to correct this imaging, we need to internally rotate that leg until the lateral foot surface is parallel with the IR and dorsiflex that foot to form a 90-degree angle with the lower leg. Go ahead and review this practice analysis and complete the following question. Let's review this practice analysis together. In this projection, again, we have closed joint spaces. You can see that the tibio-talar joint space is closed. And we have some mispositioning here. It could be rotation or it could be elevation problems. If you look closely, the medial talar dome is positioned posterior to the lateral talar dome. Also, the distal fibula is anterior to the tibia. This should indicate to you that the leg appears to be internally rotated. In order to correct this imaging error, positioning error, we need to externally rotate the leg until the lateral surface of the foot is parallel with the IR. This will assure appropriate alignment of the foot for an accurate lateral projection. Go ahead and review this last practice analysis and answer the following question. Let's take a look at this last practice analysis together. When evaluating this image, the first thing that I look for is, are my talar domes superimposed? And in this case, they are not superimposed. The tibio-talar joint space is closed and the talocalcaneal joint space is closed. Next, you want to look at the positioning of the talar domes. In this case, the lateral talar dome is proximal to the medial talar dome, and less than a half of the cuboid is visible posterior to the navicular bone. This should indicate to you that the proximal leg is elevated above the IR, and there is slight plantar flexion present in this imaging. In order to correct this positioning errors, we need to depress that proximal leg until the lateral surface of the foot is parallel with the IR. In addition, we need to dorsiflex that foot until it forms that 90-degree angle with the lower leg. This concludes the foot image analysis presentation. If you have any questions or concerns, please feel free to reach out.